Hello everyone, myself Dr. Rakesh, currently working as assistant professor in the Department of Cardiology at UN Mehta Institute of Cardiology. Today my topic of discussion is aortic arch embryology, aortic arch anomaly with vascular ring and sling. So coming to the topic, we will be covering this topic under these headings: introduction, development and derivative of the arches, normal arches and sidedness, classification, aortic arch malformation, vascular ring and vascular sling. So first of all, Martin Rathke, he was a renowned embryologist who first gave the idea of aortic arch embryology and the development, how it develops. He was first proposed this diagram of which is called the Rathke's diagram. This is the earliest diagram which is available now. So initially in that diagram, he proposed there are 6 branchial arches from cranial to caudal direction. Each of the branchial arches connects paired dorsal and ventral aorta. Although the classical Rathke's diagram shows 6 aortic arches, in reality most of the time the 5th aortic arch does not develop, or it disappears very quickly by 31st day of intraembryonic period. So the development of branchial arches begins by 2nd week of gestation and continues till the 7th week. So this is the diagram of a heart tube, where cranially there is presence of truncus arteriosus and sinus venosus is caudally. So this truncus arteriosus is connected to this aortic sac, which is formed by the aortic ventral part of the primitive aortic tube. So this heart tube is formed at 18th day of fœtal life. The first arteries to appear are the right and left primitive aorta, which fuses to form this aortic sac. Division of the truncus arteriosus is by the aortopulmonary septum, which divides the outflow channel of the heart into the ventral aorta and the pulmonary artery. So this is the formation of aortopulmonary septum, which connects the RVOT to the pulmonary artery and LVOT to aorta. So this coming to the formation of aortic arches and from the primitive aorta. So there first of all there are 2 primitive aorta bilaterally. During 5th week of gestation, they form a common tube caudally, and these arteries, the aortic arches, they arises from the aortic sac. So the portion lying ventral to the foregut is ventral aorta, and the portion which lies dorsal to the aorta is the dorsal aorta. So by week 5, this is how the aorta looks, primitive aorta looks. There is 2 primitive aorta bilaterally. The anterior part is the dorsal ventral aorta, and the posterior part is the dorsal aorta, and they are connected by 6 arches. By 7th week, 1st and 2nd aortic arches they involute, and 5th arch also involutes, and the first aortic arch gives rise to maxillary artery, 2nd arch gives rise to stapedial artery and hyoid artery, and 5th branchial arch involutes, always involutes. So by 8th week the adult aortic arch almost develops. So coming to the structures, so from the ascending aorta is formed from the left aortic sac up to the left common carotid artery, and the right aortic sac forms the right brachiocephalic artery. The bilateral common carotid artery formed by the 3rd aortic arch. Right subclavian artery is formed by right 4th branchial arch plus 7th intersegmental artery along with the right part of the dorsal aorta, which is connected to the 7th intersegmental artery, right 7th intersegmental artery. So look at this picture, the lateral view. In the lateral view, in the sixth part of sixth branchial arch is divided into the proximal part and the distal part. The proximal part gives rise to the pulmonary arteries and MPA, and the distal part of the left side gives rise to the ductus arteriosus, and the right side of the distal sixth branchial arch that gets resolved. So, from the first arch, maxillary artery, second arch, scapulae artery and hyoid artery, third arch, CCA, part of ICA, proximal part of ICA, and the distal part of the ICA is developed from dorsal aorta. Fourth part, the left sided is forms the aortic arch between the left common carotid artery and left subclavian artery. The fourth right arch forms largely the proximal right subclavian artery. The fifth part disappears. In some patients it may persist, which we will discuss later. In the sixth part, proximal part form the LPA, distal part form the ductus arteriosus, and sixth right part, proximal part form the RPA and distal part disappears. Seventh cervical intersegmental artery, they forms the part of subclavian artery. So, this is a normal left sided aortic arch. First is the ascending aorta, this and then followed by arch of aorta, then descending aorta. This arch of aorta goes anterior and to the left of esophagus and trachea and descend down on the left side of the vertebral canal. So, the first branch of the left sided arch is the right brachiocephalic artery, followed by left common carotid artery, followed by left subclavian artery. So, how this is formed? So, basically this is because of the involution of the formation of normal left arch, which includes the distal segment of right fourth branchial arch lying between the right subclavian artery and the descending thoracic aorta, right sided dorsal arch distal to the seventh intersegmental artery origin and the right sided ductus arteriosus. So, the persistence of left fourth branchial arch, which forms the definite aortic arch. So, if the left sided fourth branchial arch persists, it will give rise to left sided arch, or if the right sided persists, it will give rise to right sided arch. When there is a double aortic arch, most of the time both of them persist. Next is the ductus remains patent on the left side, like left sixth dorsal branchial arch. So, the descending aorta usually on the same side of the arch. If it is not on the same side, it is called the circumflex aorta. In the normal branching pattern, which I already said, right innominate is the first branch, followed by left common carotid and followed by subclavian artery. So, aortic arch malformation, the malformation of the aortic arch system can be explained by the persistence of some segment or disappearance of the normal segment. There are classified by various ways. It may depends on like anatomical features like arch sidedness, course and location of the arch, interruption, persistent fifth arch, or on the functional outcome of the feature like respiratory compromise or esophageal dysfunction. So, most common arch anomalies are associated with 22q11 deletion, which is called the Diger syndrome or velocardiofacial syndrome. So, the overall prevalence is around 1 to 2% and they may associated with airway or esophageal compression symptoms. So, there are multiple classification for aortic arch anomalies. One of them is surgical classification, which is divides into 4 types. Double aortic arch, which is further divided into functioning double aortic arch with partial involution of one of the arch, or right sided aortic arch with mirror imaging branching of the arch vessel with retroesophageal aortic diverticulum, and left sided ductus arteriosus connecting to aortic diverticulum. Next is right aortic arch with aberrant left subclavian artery or left aortic arch with aberrant right subclavian artery. There is a Stewart classification. There is abnormal branching of left sided arch, abnormal position of the arch like right sided or cervical, supernumerary arch like double aortic arch, interrupted aortic arch, or anomalous origin of the pulmonary artery, which is the SLING. There is another classification called freedom, that is patient may be asymptomatic or symptomatic due to vascular ring or non-ring vascular compression, ductal dependent arch anomaly like interruption, or isolated branch anomalies with alteration of normal blood flow like isolated subclavian artery, or genetic syndromes and associated anomalies. So, what are the normal variation of a left sided aortic arch? The most common is bovine arch, which is found in 10 to 20% of the cases. It is seen with a left aortic arch where all the three branches like right subclavian, right common carotid and left common carotid originate from a single trunk. And here is the pictorial description of the same. The first one is the left common carotid artery originating from the innominate artery. In the second one, the innominate in the first one, it is originating 1 centimeter above the origin of common trunk, and in the second one, it is originating within 1 centimeter. So, both you can encounter both of these types. And third one is a true bovine type. In bovine arch, all the 4 branches come from a common trunk. So, basically what we encounter is a pseudo bovine arch. So, it is not benign actually. Bovine trunk is not benign because there is only 2 fixation point and there is chance of in thoracic aneurysm formation in case of pseudo bovine aortic arch. Next common variation is the origin of the vertebral artery. The most common variation of vertebral artery is left vertebral artery originating in between left common carotid artery and left subclavian artery. But sometimes what happens, there is bilateral left vertebral artery originating from the arch. In that case, the right vertebral artery originating in between the brachiocephalic trunk and the left common carotid artery. There may be duplication of the left vertebral artery. In that case, two roots origin from the arch of aorta, one from proximal to the left subclavian artery, another from distal to the left subclavian artery, and they join to form a common trunk superiorly. So, what are coming to the abnormalities which we commonly encounter? Left aortic arch with aberrant right subclavian artery. This is the most common anomaly. The anomaly results from involution of the right fourth aortic arch. Right subclavian artery loses connection to the aortic arch, but the distal right aorta remains intact. So, the subclavian artery remains attached to the proximal DTA. So, here we can see the right subclavian artery originating from the proximal part of the DTA. So, the course is variable. The right subclavian artery may course behind the esophagus or in between the esophagus and the trachea or anterior to the trachea, but the most common course is behind the esophagus. If it goes behind the esophagus, it may not form a ring if the ductus arteriosus is on the left side, but if it is on the right side, it may form a ring, but it is rare to encounter a right ductus arteriosus in case of left aortic arch with aberrant right subclavian artery. So, but in this case it can cause dysphagia lusoria because of the pulsation coming from the right subclavian artery, which impedes on the esophagus posteriorly. They may associate with congenital anomalies like PDA or VSD or coarctation of aorta. Most common anomaly which is encountered in the 0.5% of the general population. 38 patients with Down syndrome may have this. They are associated with TOF and coarctation of aorta. So, the aberrant right subclavian artery, it may be isolated or it may be associated with Comorel's diverticulum. Comorel's diverticulum is nothing but the remnant of the right sixth branchial arch which is connected to the dorsal aorta, right dorsal aorta. So, the presence of diverticulum is a high risk feature, because if there is a presence of Comorel's diverticulum, it may be associated with a right sided ductus arteriosus, and in that case it may form a complete ring. So, if it is not associated with any right sided ductus arteriosus, it is most of the cases it is incidental finding. but in future these cases, in some cases the diverticulum of Comerus may gives rise to a aneurysm, and in those cases it need to be resected. Next, coming to left circumflex aorta. So, what we have read previously, left aortic arch is always associated with a left sided descending thoracic aorta, and right sided aortic arch always associated with a right sided descending thoracic aorta. But in some cases what happens, the left sided arch is continuous with the right sided DTA. So, how that happens? It is basically this yes, this regression is this basis of embryological basis of regression is right fourth branchial arch between the right common carotid and right subclavian artery, along with the persistent of right ductus arteriosus and right dorsal aorta. So, they form a complete vascular ring. So, here you can see there is a presence of left sided aortic arch and right sided descending thoracic aorta. So, the aorta goes behind posterior to the trachea and esophagus and becomes continuous with the right sided dorsal aorta, and there is presence of right sided ductus arteriosus which completes the ring, and it leads to dysphagia and grunting in babies. So, the left aortic arch with circumflex aorta may result in a severe tracheobronchial compression leading to respiratory compromise. In such patients, compression may be relieved by only the division of the ductus or ligamentum arteriosum. So, the coming to the right aortic arch. So, by definition is single aortic arch that crosses over the right mainstem bronchus passing to the right of the trachea. The anomalies associated are congenital cardiac anomalies, esophageal atresia, tracheoesophageal fistula. What are the association with the CVS? Truncus arteriosus, TOF, pulmonary atresia of VSD, tricuspid atresia and transposition. There are three types of right aortic arch. Right aortic arch with mirror imaging branching. Next is right aortic arch with aberrant left subclavian artery, which is the most common type. Then third type is right aortic arch with isolation of the left subclavian artery. So, first coming to right aortic arch with mirror image branching. This here you can see the first branch is from the first branch is left brachiocephalic, which gives rise to left common carotid and left subclavian artery, followed by right carotid artery and followed by right subclavian artery. The ascending aorta goes right and to the anterior of the esophagus and trachea. So, usually they do not form a ring because the ductus is left sided and it is connected to the base of the innominate artery. Next, coming to right sided aortic arch with aberrant left subclavian artery. So, this is the most common type. The first branch is left common carotid followed by right common carotid followed by right subclavian artery. The last branch is the left subclavian artery, which usually takes retroesophageal course, but in this case the ductus is right sided. If it is not forming a complete ring, then the ductus is right sided, but if it is forming a complete ring, then it is left sided with the presence of Comerus diverticulum. Usually this happens. So, if it is right sided ductus arteriosus, so it will connect the RPA to the base of the subclavian artery. So, the ring is not completed, but in case of left sided ductus arteriosus, it will connect to the it will connect LPA with the Comerus diverticulum. So, in that case the ring is completed and it gives rise to vascular ring and compression. This is the same, the right aortic arch with aberrant left subclavian artery arising from the diverticulum of Comerus. So, here what happens, the complete ring is formed by aortic arch on the right side, retroesophageal vessels supplying the left subclavian artery posteriorly, the ductus on the left side and the pulmonary artery on anteriorly. So, here also the ductus division is required. So, RA with isolated subclavian artery, Here what happens, this is because of the regression of embryological left fourth branchial arch along with dorsal aorta. Left subclavian artery remains attached to the sixth branchial arch, and the left subclavian artery arises either from the vertebral artery or from the ductus arteriosus. Most commonly it arises from the ductus arteriosus, as it is ductus arteriosus is a part of sixth branchial arch. So, what happens in this case, if it is arising from the ductus arteriosus and if the duct closes, then there is chance of acute limb ischemia, or in case it is arising from the vertebral artery, it leads to subclavian steal syndrome. Unlike the type 2 RA, type 3 is associated with increased incidence of congenital heart disease like truncus, tricuspid atresia or TROF. So, this is a diagram depicting left subclavian artery arising from the ductus arteriosus. So, it is important to maintain the patency of this left subclavian artery, or patient will have acute limb ischemia when the duct closes. Now, like the left circumflex aorta, there is right circumflex aorta, where the right sided arch is continuous with the left sided descending thoracic aorta. Here also same, there is also a left sided ductus which forms the complete ring, and it may lead to completion of the ring and compression. Next is double aortic arch. Both the right and the left fourth branchial arch persist here, leading to the double aortic arch. The common carotid and subclavian arises from the ipsilateral arches on both the sides. This arrangement encircles the trachea and esophagus completely and is the most common cause for complete vascular ring. The ductus is usually left sided and it is seen ipsilateral to the side of atretic arch. So, what happens here, the descending thoracic aorta is almost always is contralateral, and most of the time the right arch is dominant and it is more cranial as compared to the left arch. There are a lot of variation. Both arches widely may be patent. Maybe there is one hypoplasia of the left arch, or there may be atresia of one arch. So, descending aorta is almost always left sided in double aortic arch. 22% of the cases associated with TOF and TGA, which is most probably because of velocardiofacial syndrome. So, persistent of the fifth arch. As we know, the fifth arch is usually non-persistent and it goes by 31st day of life, but in some cases it may persist, in which case there is a connection between ascending aorta to descending aorta or ascending aorta to PDA and to connect it to the LPA. So, when it is connected between ascending aorta and descending aorta, the two arches may be both are patent or one may be hypoplastic. So, this is a CT scan showing a persistent fifth aortic arch, where the from ascending aorta the fifth aortic arch arises. It is continue as a LPA through the patent ductus arteriosus. In other cases, it may continuous between ascending aorta and descending aorta. Whenever you are finding something in the ascending aorta connecting to the descending aorta or the LPA, suspect of persistent fifth aortic arch. So, the clinical presentation, it depends on the connection, whether it is systemic or pulmonary, as I have said. So, it is hemodynamically beneficial if it is associated with coarctation of aorta when systemic to systemic connection is there, and is in systemic to pulmonary arterial connection, it is beneficial when there is tricuspid atresia or pulmonary atresia. Next is cervical aortic arch. In this type, the aortic arch is seen at abnormally high position, reaching at or just above the level of clavicle, presumed to be arising either from the persistent second or third branchial arch, with regression of the normal fourth arch and from failure of caudal migration of the normal developing fourth arch. Cervical aortic arch complex consists of high position of the aortic arch in the superior mediastinum. So, the clinical presentation is usually a pulsatile neck mass. Majority of the patient do not require surgery, as the anomaly does not result in compressive symptom. It is commonly found in any intracardiac defect associated with right sided aortic arch and 22q11 microdeletion syndrome. So, this is a CT scan depicting cervical aortic arch. So, the normal common carotid artery comes about the dissolution of the segment of dorsal aorta between the third and fourth embryonic arches, the so called ductus caroticus. But if the ductus caroticus were to persist while the embryonic fourth arch involute, the embryonic third arch would become the definite arch with separate internal and external carotid artery arising from it. Next is interrupted aortic arch. So there is basically three types of interrupted aortic arch classified by Selorian pattern. Type A is the interruption between distal to the left subclavian artery. Type B is the most common, it is between the carotid and subclavian artery, and type C is between the carotid arteries, which is very rare. So it is basically this is a problem of invagination of the neural crest cell. So it is not like a problem with the aortic arches itself, but it is the problem with the neural crest cell invagination. Next is the coarctation of aorta. This is also same. It may be preductal, juxtaductal or postductal. There should be a gradient of more than 20 mm to call it as a significance coarctation of aorta. CT angiography is able to provide the anatomical details of the site and degree of narrowing and relationship of the coarctation to the arch of vessel. So this is coarctation of aorta, as you have all know. So vascular ring. Vascular ring is an aortic arch anomaly in which trachea and esophagus are completely surrounded by vascular structure. The vascular structure need not be patent, such as it may be ligamentum, it may be atretic segment of the aortic arch. So clinically they present with stridor and also cause pneumonia, bronchitis and cough. So complete ring, 50% of the complete ring is by the double aortic arch, and others are right aortic arch with aberrant left subclavian artery, right aortic arch with mirror image branching and retroesophageal ductus, and circumflex aortic arch. So final one is the SLING. So what happens here? The left pulmonary artery arises from the right pulmonary artery instead of arising from the MPA, and it courses through the between the trachea and esophagus, leading to tracheal compression. This is the diagram of this SLING. So this is the final embryological basis of all the aortic arch anomalies. You can pause it and read. Thank you.